Welcome. Here we are, ASMBS 2025, Washington, D.C. We're here with Dr. Sekhar. I am looking for this conversation. We were discussing you do same-day bariatric surgery. Now, I had the luxury, I was at ASCARS recently, and I was talking to some of them. They're doing same-day colon surgery. Not that that was mind-blowing, but apparently everybody's doing this now. So can you tell me, what is it about bariatrics that allows you to do same-day? And then how did you create this system to do it?
Yes. So, it goes back to COVID, when we had a situation with COVID where we couldn't operate for 2 months. And part of our impetus for doing surgery in a surgery center came to be that we noticed that the spine surgeons and joint surgeons were still able to operate in their own centers. They weren't constrained by not being able to continue to operate. Even though this is a life-saving surgery, it was considered elective and we weren't allowed to offer it. So we started investigating doing these surgeries in a surgery center. And the sleeve gastrectomy, which is a surgery that takes me about 20 to 30 minutes to do, seemed to be a perfect fit. So we started doing surgeries in our surgery center, and we've done close to 2,000 with really good outcomes. My typical patient will stay in our surgery center for 2 to 3 hours and then be able to walk out the door and spend their first night at home instead of in the hospital with other patients and nurses who may be taking care of a multitude of other patients. They have that focused care from our well-trained staff who all they do is take care of bariatric surgery patients.
And when you want to say, let's say I was going to set something like this up, what do I have to be paying attention to make sure that these patients are safe to go home 3-4 hours after I've done a procedure that lump?
So you have to make sure that they're a good patient to have surgery in a surgery center. So they can have multiple medical comorbidities. If they're a patient who's just had a stent within the last 6 months or BMI is 70, that's a patient who should be done in the hospital. So it should be a patient who BMI is around 35 to 60 and has very minimal medical issues and is going to be able to get up, walk around, be compliant with exercise and drinking at home. So a lot of it comes down to patient selection. So initially, if you're embarking on this journey, don't do your 65-year-old BMI 60 patient with heart issues and severe sleep apnea as your first case. It should be a smaller patient who is going to be successful with the surgery and with really getting up and moving around after the surgery, which is really critical. And it's something that is a clear benefit from doing these surgeries in the ambulatory center because we get our patients up and moving around within 30 minutes. And in the hospital, they might not get up and moving around until 8 hours after the surgery. I've heard from patients who I've done surgery at the hospital and they never moved from the time we did the surgery till the next morning, and they had to ask someone to come and help them move around. So that's not conducive to good outcomes or decreasing the risk of DVT or other complications of the surgery. So for my patients, I find that they have a better outcome and lower risk of complication doing them at the surgery center versus the hospital for that select group of patients.
And when we're looking at it from a technical standpoint, so obviously that's the perioperative standpoint, but technically in surgery, have you made any changes that you found were beneficial to their outcomes that other surgeons could adopt relatively easily?
Yes, so that's a good point. When I was embarking on this journey, I went and saw one of my partners in New Jersey do surgery at our surgery center there. And one thing that he pointed out was lowering the pressure. So he lowered the pressure to 12. And when you do surgery in the hospital, you're kind of indifferent to the pressure. You see the patient the next day. They don't have much pain anyway, but when you are doing surgery with the intent of discharging them the same day, you're very acutely aware of pain. And so what he told me was that at that lower pressure, the patients had less pain. So I started investigating it and lowering the pressure. And that's when I started using the AirSeal system that is made by ConMed. And with that system, I could get down to an 8, pressure of 8, sometimes as low as 6, and still have enough working space. So one game changer for me to let people go home within 2 to 3 hours after the surgery is running at that very low pressure. So a pressure of 8 makes the patient have less shoulder pain, less chest pain, less nausea. So in fact, our rate of return to the ER or another center for IV fluid is extremely low as well, less than 2%. Nationally, that rate is around 10%.
So you believe that having lower pressures was better for pain, better for fluid, post-discharge fluid requirements, and overall ambulation?
Yes. So the lower pressure the first thing that you see is less shoulder pain. I'm sure you've heard from patients when you do laparoscopic or robotic surgery with a pneumoperitoneum, one major complaint is the shoulder pains from that diaphragmatic irritation.
Yeah.
And that is primarily from running that high pressure, that 15 to 18 to 20 millimeters of mercury pressure that we all thought was necessary in order to have a big working space. So what I noticed with the AirSeal system is that I could get that same view at a pressure of 8. Whereas with other systems made by some of the competitors, I could only see that view at 15 and higher. I could see that same view at 8 and get a nice big view and have the patient have less pain. But also, interestingly, I heard from the anesthesiologist, who we really work as a team in the OR. So my anesthesiologist will also run a lower tidal volume. So as surgeons, we don't think about tidal volume or the respiratory rate. But this is something that I learned because in order to have enough space, the anesthesiologist has to, in some cases, run a lower tidal volume and a higher rate. And that gives you much more intra-abdominal space. So the other thing that the running at a lower pressure does, I'm sure you've run into this situation where the anesthesiologist will tell you, let all the air out. The pressure is dropping, the patient's getting bradycardic. I have not seen that since I started using AirSeal. So in over 200 cases, I've never had the anesthesiologist tell me, stop what you're doing, let all the air out, lay the patient flat. There's nothing that disrupts your flow more than having the anesthesiologist tell you that, right?
Yeah.
And that's something that I have not seen since I started using this system, which in order to stay in the flow of the case, you are going to have a really good day when you don't have to break the flow of the operation, right? You get into that zen, that flow state when you're in an operation, and there's nothing worse than hearing these alarms going off and telling you that you have to step away from the table when you're in that zone.
I always think it's funny. When you're in the operating room, 2 minutes, 3 minutes of waiting for them to correct something feels like a lifetime.
It does.
And you're just sitting like, oh, come on. And then you realize it's probably only been 5 minutes, but it just puts your whole day behind. And especially if you're running a lot of cases.
Right.
I had this conversation earlier. It's like, you run 10 cases a day, 5-10 minutes. That's an hour. That's a couple hours.
Time adds up.
It adds up real fast.
That time adds up. It's like dog years. 1 minute in a surgeon's time is probably like a year in a normal person's time.
And the truth is, it's expensive time. Like if people say that, I mean, what anesthesia now, they calculate down to, I think down to the minute, hell, it might be the second at this point.
Yeah. Well, and in our ambulatory center, things like that add up. So I've done 8 surgeries in a day and had all of the patients out the door by 3 o'clock.
Wow,
so that makes sense and economic sense for an ambulatory center where if you have 8 patients who are staying for an additional 4 hours, that's a lot of overtime that you're paying to staff to stay and monitor the PACU. So for us in our center, it really makes economic sense as well to have patients have a short length of stay, very minimal pain. And a patient who has a good experience will tell 5 people. A patient who has a poor, painful experience in an ambulatory center will tell 20 people.
As you say, that's a lot more.
So it's really good also for word of mouth to have patients have a great experience. One of my colleagues was telling me that he was working in another center and they told him that a patient had surgery at our center and the only thing that he would talk about, or the thing that he was really happy about, was that he had zero pain and did not feel that he had surgery. So that's something that I attribute to good surgery, early ambulation, but also that low pressure surgery.
And I'm going to assume too that you've really incorporated the ERS protocols into this whole system.
Correct. Yeah, we give Toradol, which is something that I was always afraid of as a surgeon. I thought staple line is going to bleed, we're going to have problems, but we give intra-op Toradol. We do all of the other factors that are a part of that program. But the biggest game changer has just been lowering the pressure. And something that I always tell surgeons who are kind of feeling a little bit of anxiety about running the low pressure is I let them know, just be blind to it. Let someone else take the wheel. I know as surgeons, we always want to be the captain of the ship and really standing at the helm. But with the pressure, I just tell the staff in the room, just as soon as I get the ports in, lower the pressure. Don't tell me what it is. Because part of that gets into your head, what the pressure is.
Yep.
And you feel like at a lower pressure, you're going to see less. You're going to see less. If you're not aware of what the pressure is, your view is not going to change. So a lot of it is just having some trust in your abilities and getting over a minor learning curve, probably 5 or 6 cases if you're an experienced surgeon and you get over the hump.
Now I'm assuming it's going to become the new normal. Once everything becomes the new normal, it just is what it is, and you move on. So let's go to a broader ASMBS kind of question. GLP-1s, here to stay, everybody's talking about them. Where do you see them in the bariatric world?
So I see them as a Venn diagram where there's going to be big overlap. We've seen with, I always use the example of heart surgery. If you have a bypass or a stent, you don't stop taking your aspirin and your Lipitor, you stay on them. So if you're a patient who's on Ozempic, you stay on the Ozempic after the surgery, you stay on the Wegovy after the surgery. There's a lot of benefit for patients, especially after revision surgery, to go on a GLP-1. So I do medical weight loss. I encourage all bariatric surgeons to do medical weight loss and get involved with it, because we are the masters of weight loss. And there's no reason to give away control of that treatment to people who have very little experience. If you have taken a class and you can get A-bomb, that's no comparison to doing this for 20 years like I have. So I feel that the real experts in weight loss should be managing medical weight loss as well. So there's a big overlap, and patients benefit from listening to your experience and knowing when to pull the trigger, because you can see when they're going to either do well or not do well on medical weight loss. If they see someone who only does medical weight loss, they're going to give up, stop the medication, and then not seek further treatment. Whereas if they see a bariatric surgeon, you have something else that you can offer them.
Well, I was talking to Dr. Rogers earlier, and I think I agree with you 100%. It opens a door for patients that probably have heard about surgery. They don't want to do it. They'll say, because I might want to send somebody to bariatric surgery, like, I don't want surgery, and I've seen dietitians, it doesn't work. And it's like, yeah, but go talk to them, because we can try medical. And it starts to get that conversation going about the problem, about the fact it's a chronic disease. It gets them in the door, but without having the other modalities. If you're just doing medical management, I can see, it's like anything else. It's the old, if all you have is a nail, all I got is a hammer kind of thing.
That's right.
Whereas in this case, you get them in, and then they start to get comfortable in that conversation. You really start to explore all the options and take some of that fear out of them that potentially they have. So.
And it can be a bridge to surgery. So I have many patients who come in and they hear about surgery, and they go for surgery at that first visit because they understand that it's a better option if their BMI is 50 plus. It's a better long-term option for them than being on a medication. And then I have another subset of patients who want to try medications for 3 to 6 months. They want to prove to themselves that they've exhausted all of the non-surgical options. And then they feel that they have autonomy in making their decision, and then they go for surgery. So it's definitely, for many patients, it's a good bridge to surgery, and it keeps patients within a safe pathway where they start to feel comfortable with you, your staff, the other people that you work with, and they feel that they're going to be well taken care of. And they don't feel that fear factor with surgery anymore when they realize that you're a human and you empathize with their condition as well.
So as a bariatric surgeon, I'm sure you have thought about this extensively. If there was one thing going on in our system that's creating this epidemic, what would you point at as the number one cause? Everybody hates to answer this, so I kind of want to.
So I think it's a combination of two things. I think it's certainly the diet that's been stressed, that there's factory food, there is processed food, but it's also people don't have the activity that we used to. You know, as kids, we were feral kids growing up in the 80s. We were outside constantly, running around, biking everywhere. And we also at school, we spent a lot more time playing outside. So our physical activity as a society has really declined. People spend a lot more time in front of screens. So it's a combination of two things. It's diet and a decrease in physical activity. So the way to combat that is to change diet and increase physical activity, especially weightlifting. I know this is a conversation that we've had before, but I learned this too late. After age 50, I realized that I needed to incorporate weightlifting into my workouts, and I lost weight, and I felt better too.
Yeah. But even the way you say all that, though, I'm afraid it comes across as like diet and exercise is key, when the reality is we know that once you get to a certain point and the inflammatory process has begun and you're trying to lose weight, losing the weight once you put it on there it's not as simple as just working out and changing your diet, because that set point's there. And I really have, we had this conversation in the pre-interview, but once you establish that set point, it's almost impossible to change it.
It's very difficult. And that's where medication and surgery come into play. So I think there are some societal and diet factors that have gotten us to this place, but there's no societal or diet cure. We have to incorporate medication. We have to incorporate surgery. And one thing that really reduces the fear factor of surgery, in my experience, is offering ambulatory surgery. A lot of patients are really scared of being in the hospital. And when you tell patients that this is a surgery that we can do in our surgery center, where you have a team that's really focused on your recovery, and you get to recover at home and spend the night in your own bed, that really decreases the fear factor for surgery. So the fear factor for doing surgery in an ambulatory surgery really comes from the surgeons, not as much the patients.
Do you see ambulatory bariatric surgery as becoming the standard of care over the next 5 to 10 years?
I do.
Where is it currently? What's the adoption look like currently?
The adoption rate is extremely low. So I think we as a group are on the cutting edge of this at this point. I don't know the statistics nationwide, but I would probably estimate less than 1% of bariatric surgery is being done as outpatient now.
I know
and now about 80% of our surgery as a group is being done as outpatient.
Really? So the whole group's kind of taking this though?
The whole group has really taken the bull by the horns and living in that uncomfortable zone.
I will say that we learned this on the hernia side, though, is once you get to that 50% plus one mark where they're doing more than 50% of the cases as outpatient, they reevaluate that whole CPT code, and they start to look at the reimbursements on it, and the government comes in and changes it all because you've now made it an outpatient procedure. Is that something that as surgeons we should be worried about as we try to develop? Because I do think outpatient's generally better if you can do it, but at the same time, it's a self-fulfilling problem.
It is, and that is above my pay grade. I leave that to the brain trust of ASMBS and leaders like you to figure out a good way of dealing with the issue. You know, we talked about this. There are very well-funded groups that want to pay us less money. So we really have to figure out a way of having the same leverage in DC. We're in DC. We need to figure out a way of having the same leverage with the decision makers that the other big players like insurance companies and pharmaceutical companies have. So that's the big challenge, because we're not a unified front like they are.
Oh, I know. And it was interesting. I had the opportunity back at Sages. I got to interview Dr. Roth, and he's the representative for surgeons at the CPT code system. and you hear how it works. It's brilliant if you're a bureaucrat. I mean, they built this to basically make the doctors fight each other for the money and sit back and be like, what was your guys' decision? And the reality is it just keeps from wanting to innovate, because if you innovate and do what you're doing, then it's going to end up costing you money in the process. But it's so hard to stop a surgeon from doing what's better for the patients. So how do you stay out of that cycle? So that's something we really need to evaluate.
Well, they depend on our altruism.
Oh yeah,
right?
Absolutely.
And they take advantage of it.
Oh yeah, abuse it, I would say. They really do.
Yeah, but we have to stay true to our vision and our mission, which is to help as many people as we can, and to help them in a way that encourages other patients to seek the same care.
Yeah, no, I agree. But that being said, I want to end on I ask everybody, if there is something that you would call that pearl of wisdom, the thing that you've learned from experience, but not in a textbook, that you would either want to tell other surgeons or maybe somebody you train, like a resident or fellow, what would that thing be?
So I would say life begins at the edge of your comfort zone. So if you were getting into a state where you feel very comfortable doing what you're doing something wrong. You need to challenge yourself more. So if you find that life is becoming too easy, take on another challenge. So the challenge that I'm taking on is doing my surgeries at low pressure, because I feel even though it's more difficult, the difficult things need to be done because they help the patients.
Absolutely. No, I respect that a lot. I completely agree with what you're saying. That tingling in your spine, if you're not getting that every now and then, where you're like, oh, then you're probably not challenging yourself enough.
Push the envelope.
Exactly. Well, thank you so much for your time here on The Cutting Edge, and look forward to talking to you.
Thanks for your time. I appreciate it.
Pleasure.